Hey, here's another whiteboard, probably pretty wild. Try to make heads or tails. Not nearly as busy as the one I posted on stories, but this one's a little bit interesting because it's a very interesting potential cascade of events. I am primarily going to be referring them to other people, some of which I don't know, and I also use some words that I typically don't use in front of patients. I try very much to stay away from exclusive words, like words that have a significant role in scientific or very formal diagnoses or constructs, so that I try to do that so people can't really look them up and get all scared by different things. But this young lady seemed to know quite a bit. It has some bits and pieces of where I've recommended that we go with this, which is very, very positive because at the end she was saying that I've heard some of these things in other places, but very, very typical where really very, very fragmented, very segmented approach to care and treatment. But in some ways, when we know what we're getting into, we can use different practitioners or different models to our advantage rather than let them use us. So there'll be, as usual, several side messages that we'll get through with this outside of the clinical approach and the thought process. That's what this is really all about, just giving you a little window into how I think, and in this case, how I'm not going to be the one to probably provide the best or most important help to this particular individual. So this started. Her primary complaint is neck pain, neck motion. There is an MRI. It doesn't look great, but again, we know that remains to be seen if it's relevant or not. Also, very interesting, a very hypertrophic clavicle on the right side. No history of fracture, and it's actually very uniformly hypertrophic. So it's not just one area where the callus of the fracture was. And it does appear to be more mobile than the other side. So I had actually seen her as a quick consult, passing by kind of thing, and showed her how to do the sternoclavicular Eldoa, which may or may not have anything to do with it, but very interesting. And I explained this to someone else yesterday. Sometimes the Eldoa can be very, very good for mobility, but also very, very good for stability, since they're very, very high tension approach. And it probably has some very, very good parallels to how tissue changes and how motor control is gained or learned moving forward. Issue is the neck, but then where did this all start? So 2 years ago, in her words, a panic attack, or basically what was confusion in regarding a cardiac event, went to the emergency room, described significant pressure shoot through the chest, really not in a very good place. So with that, we had other imaging that she brought with us, which was chest x-ray, chest CT, a bone DEXA scan, and abdominal CT, because she also felt that whatever was happening had some impact into her abdomen, where she had some significant symptoms of filling through the abdomen. Okay, so all of those things did not reveal a cardiac event, which I do think is a fairly reliable expectation to know when you leave the emergency room. Nothing showed up on CT, etc. But really her complaints outside of the neck that sometimes lead to headaches, but also multiple bouts of dizziness. Periodic, intermittent, so not something that dramatically affects this individual's life, but something that is very, very much a part of this whole construct. And at the beginning, as she described this, obviously I would typically say to anybody, everything is relevant until proven otherwise. So tell me everything, and because it might be something that the person or the patient or the client doesn't even think matters. That being said, dizziness is probably going to be one of the most important signs or symptoms that this patient describes. So everything is relevant until proven otherwise. Or maybe the verbiage to the patient is, hey, even if you think it is completely unrelated to your neck or why you came to ask for some help, anything else is on the list. Even if it happened years ago, we're trying to pull out information that maybe the person doesn't think is that important or that relevant, but actually in this case, one of those pieces turned out to be very, very critical. Okay, so her symptoms were thoracic, because now those symptoms can be provoked in a non-emergent fashion by looking down, whether looking down at the book or the phone. And that seems to be a provocateur. So I'm starting to think, and this is not part of the discussion with the patient, I'm starting to think, okay, so from a bone, muscle, and nerve a thought process, can anything there lead to really increased heart rate or this highly sympathetic environment that does appear to be some kind of potential cardiac or cardiovascular or pulmonary event? I don't know what that is. I may not be thinking of something very, very simple, but there's nothing directly. There's no, these are thoracic discs, which I don't think really, at least in my experience, don't really happen that much. We would be able to be more reliable as you look down. Those are obviously posterior neural structures that are primarily being opened or potentially affected. There could be compression anteriorly, but would I expect that to be front and back symptoms directly? I don't think so. There's nothing there that makes a lot of sense. So that then we start to think of, okay, well, what can be causing that? And this we did discuss. So we can get to from the chest X-ray, and there are we talked about this in a recent video in terms of how do we compartmentalize something that is medical versus something that is orthopedic versus something that's neuromuscular. Well, clearly the upper thoracic symptoms in anterior and or posteriorly can certainly be a medical issue. It's why in the emergency room they did proper tests and they ruled it all out, which I think is fantastic. So a lot of times people get very frustrated with the traditional medical system, which I think I'm a part of. I don't think what I'm doing is not traditional or even outside the box. But that being said, people get frustrated because they didn't get to the root cause. Well, that's not the purpose of an emergency room. Emergency room is to make sure you don't die. So that's why sometimes people ask, well, should I go to the emergency room? I'm like, yo, they're going to make you wait like 6 hours, because once they realize that you're not going to die, you're not going to be triaged with the same priority as others after that initial triage. But great news, very positive, and again, I'm harping on this with the patient who's not anxious in front of me, but they're confused. They want answers. Well, hey, some positive things is that we know that this is not going to be a frank medical problem. It's not going to be the heart, the lungs, what else could be there? The thyroid and all of the other glands in this particular area. I'm trying to think, obviously the diaphragm could be referring north, but I think we're primarily talking about those components there in terms of the heart, the lungs, and some of the things that we'll see in the anterior throat. But because there are some glands, particularly the thyroid, and I'm not even thinking of the dizziness just yet, but I do think that it is reasonable for this person to have 2 years of these types of symptoms and not have any result. I have to start to think that maybe there's something more systemic. Is it possible? Remember too, after I've already set the stage for the explanation, that they're making sure that your thyroid is not going to be this problem that thinks you're going to die. But if there's a marker for a certain organ or blood work or something that can be measured numerically, and that number is very low normal. So let's say this magic number for organ X is a 5, and they measure you as a 5.2. They're going to say you're fine. Well, do we really think that over a 7-day period, much less a 2-year period, that number has not gone as low as a 4.2, where if that day in that particular snapshot under significant load or stress, that number was a 4.2, they may take a completely different medical approach on how they deal with organ X. So in that regard, sometimes some of these things may not be a frank medical problem by the most valid and reliable tests that the healthcare has, but it may be something like a sensitivity, not necessarily a full-blown allergic reaction, where if these organs are now underperforming or not optimal, they talk and the body tries to have a conversation. So maybe some of these pieces where maybe they're ruling out a tumor in the anterior throat area, maybe these different things are just overworking and creating this particular environment. She then mentioned that history of dairy, whether it used to be an allergy, she said she outgrew it. Well, maybe it's no longer an allergy, but it's just a sensitivity. And then that creates the sympathetic response that brought her to the hospital in the first place. And there's going to be a link back to the neck, because this is always going to be a team approach. So I use the word sympathetic and parasympathetic because she seemed to know the words. We talked about fight or flight, sleep, sex, and digestion. So is it very possible that there's something organic that is leading to that response? Well, I think that's possible, but that's going to kind of go in our pocket because this is now reliably reproduced by looking down, which leads us back to that dizziness approach. And I do believe that, and I don't have this stuff memorized because I think you can just look it up when it's needed, because I don't see it a lot. If you look down, I think it's the posterior semicircular canals, which would be one of the components of some kind of the Hall-Pike maneuver in which to treat. Well, is that also very reasonable that excess tension through the posterior cervical area, whether it's joint, bone, etc., could that be creating fascial tension around the autonomic chain, which is relatively this low-hanging necklace around the back of your neck? I'm like, I think now we're starting to link what could potentially appear to be a vestibular issue, a sympathetic issue, and a very, very tensioned neck that simply doesn't have ideal positions to absorb and adapt to stress. So where are we going to go with this? I mean, and that's just storytelling. The neck has all the everything you would expect: cervical rotation, asymmetrical, same side pain, so closing joint symptoms, etc. Single leg stance, perfect. Single leg stance, eyes closed, we didn't see anything. We still looked at the makeshift foam and dome, 2 Air-X pads, 1 second cadence side bending, 1 second cadence rotation. I know there's bigger and badder versions of some of these vestibular tests, but nothing showed up. That being said, I don't care, because maybe the reason nothing showed up on those vestibular tests is because her neck doesn't move that far in the first place. Maybe her inability to self-recorrect the position of the crystals in the posterior semicircular canals is because she can't move so much. And maybe she's really, really good at blocking motion of the neck to prevent what would appear to be dizziness at some points, and at other points manifests through this incredible sympathetic event. Because just because you don't say it's dizzy, because you don't perceive that it's dizzy, then you just get really, really anxious and you get all revved up into this incredible sympathetically driven environment. Now, I don't know if any of this stuff is happening, but other people do. So I'm going to say what I've suggested is that I can help you improve how your neck moves, and we'll see what happens. But I do not think that should happen in isolate. I think it should happen in parallel. I think we should probably examine some, lack of better term, functional medicine, because this individual has significant history. I do think it should be someone who's credentialed, not somebody who learned it on their own. That's my opinion. My opinion is also that you don't need to have a certain degree to have a certain skill set. That being said, for not my legal purposes, but overall, when somebody has concomitant medical issues, I think somebody should have a more terminal degree and have some level of credential that they're not going to do any harm. Moving forward, I think the real winner is going to be with a vestibular trained physical therapist or a neurological chiropractor. I kind of put those on par, even though if you're a neurological chiropractor, you won't agree, and if you're a vestibular physical therapist, you won't agree. I'm giving the patient the choice, and there's and my familiarity with that neurological chiropractor piece, obviously with my experience in Toronto, it's a little bit more normalized and less voodoo-ish than what we might perceive here in the United States. So I tend to think that the neurological chiropractors that I know of, this would be something like, wow, that makes perfect sense. Now, the only other thing that we can start to look at, I do think treating the neck from a neuromuscular standpoint could potentially deload the autonomic chain. I learned from Mark Sabatici years ago how to needle for the purposes of perineural effect in that low-hanging necklace, if you will. Additionally, we may be able to further look at, are there any specific mobilization strategies? In this case, commercially, I'm thinking of global postural stretches. I have to look this stuff up to see what's available, that if we were to create some kind of stretch that really mobilized the fascia in this general area, does that have a decreased occurrence of looking down and having these dizzy or chest, these chest front and back symptoms? So it's really, really interesting, but I'm not going to be the guy here. I think there's probably a lot of other people equally as competent of helping this young lady improve her neck motion. There's not a lot of people that are going to be able to take a look at this piece or really have a very keen look and be a lot more comprehensive in their testing than standing on a leg with eyes closed in a makeshift foam and dome. I don't even know or care if the interventions are more vestibular based. I think sometimes when you see some of these folks that have that type of training, they're like, oh, that's not vestibular. No, I think if you see somebody bury a single leg stance and then they can't do anything with their eyes closed, I do think that's a very, very useful screen to kick someone to potentially more tests and maybe more formal tests. The vestibular system. But you will see that when nothing else shows up. Just because this young lady had a stiff neck, there wasn't a whole lot of other things that would yield this type of referral symptom front and back. Great news, though, that I harped on a couple times. Her folks at the ER did her right. They maybe didn't do it complete to the patient's satisfaction, but the great news that none of these symptoms today, we think, are coming from anything that's really, really dangerous. So that's why, I write this stuff down and then I stare at it, and in case I'm not seeing something, I really think that writing things down is the answers will come back and stare at you. But when you talk it out, and then you're talking about it with the patient or the client. Most of the time this is a patient. If it's more of a fitness and a training environment, sometimes we'll do this, but it's more of like you're trying to figure things out, and it makes them feel like they're a part of it, which is not a trick. I absolutely need them to be a part of it. So I did use some of the exclusive words, which I've talked ad nauseum. I don't think is always a great idea. In this case, how did I know? I don't know. I just know, and we'll see if it was a good idea or a bad idea. Typically, I don't want people looking at that stuff up, but it would make sense as to where we're going with this. I think this will be solved as a combination of improving neuromuscular function of the neck, but also I think there's going to be a vestibular piece, and it remains to be seen how they're linked. Hopefully that makes sense. And anybody happen to be in the Crichton section of Mobile, Alabama, and you've seen a leprechaun, say yeah.